Alright, so arteriovenous malformations, also known as AVM. It's a congenital anomaly resulting in a faulty development of arteriocapillary, venous, or lymphatic structures, or any combination. They're thought to be present at birth and do not represent neoplasms. They're thought to be present. We'll kind of talk about that here in a few minutes. Abnormal tangle of blood vessels reduces the amount of oxygen-rich blood that reaches the heart and the brain. The veins and arteries are directly connected without capillary beds to separate them. So there's a lot of regurgitation, a lot of back and forth of oxygenated and deoxygenated blood, which will lead to problems. According to AANS.org, AVMs occur 1 in every 100,000 cases, and 2 of those 3 cases occur before the age of 40. Currently, causes for AVMs are unknown. There's a lot of research out there, but it has not been proven one way or another where or how AVMs are formed. They are not considered to be genetic, nothing passed down, it's just kind of you have it. Outcome depends on the location, size, and the amount of bleeding. Obviously, a ruptured AVM is going to bleed a lot more than one that has yet to rupture. If it's caught early and treated correctly, the patients have an excellent recovery rate. The prognosis goes up if it is caught early, just like many other things in the healthcare field. It's most commonly associated with stroke, hemorrhagic or ischemic. And treatment is determined based on the size and location. There's 3 main treatments: radiosurgery, microsurgery, and embolization are the 3 different ways that we can treat it. The causes are not known. Again, some believe that it's occurred in utero when the baby is being developed. There's an abnormal development or a lack of development in the brain that causes the arteries and veins to connect with no capillary bed. Other scientists and physicians believe that it occurs after a stroke. But there's not enough research to conclude one way or the other at this point in time. If AVM ruptures, it may cause permanent neurological damage. The best round of treatment is discovered after imaging's been completed, reviewed. Again, at that point in time, the physician will meet with the patient and discuss the best treatment options. Again, it's often associated with stroke. It's unable to be biopsied, but they can remove it through open brain surgery. And follow-up exams and procedures are determined by the physician based on the status of the patient. So there's a lot of case by case. There's nothing set for follow-up. Treatment is also determined by the patient's age, size, and location of the AVM. Obviously, there's always risks, and there's many different symptoms. Following the discovery of the AVM, a surgeon would be notified. A surgeon would review the images, meet with the patient, talk to the doctors. They would discuss the best method of treatment for this patient. It is a case by case. Same treatment doesn't always fit with every patient. And this is a point where they decide on how they should treat and which direction. Breaking down those 3 treatments: open brain surgery is just like it sounds. You remove a piece of the skull, remove the AVM, and then put it back together. Embolization is when they stick a catheter through the artery up to the AVM and they inject a glue-like substance that slows the flow or stops the flow through that particular portion, and it forces the capillary beds around that AVM to receive more blood, which allows it to deoxygenate the blood. so it can be treated that way. And then stereotactic radial surgery is when they shoot radiation at the AVM in hopes that it will cause that vessel to shrink and reduce the risk of bleeding. So my case study was a 25-year-old female who reported to the emergency department. She had chronic headaches, migraines, she couldn't get rid of them, no relief no matter what she tried. They ran labs on her, they came back normal. There are no labs at this point in time that are able to lead to or confirm or diagnose an AVM. So when the labs came, the physician ordered an MRI of her brain with and without contrast. They wanted to visualize this blood flow and see what was going on. And you can see that in this little diagram, the normal capillary bed versus the AVM, where there's a lack of a capillary bed. Here's a couple of pictures from that slide or from that MRI. You can see that AVM is located in the occipital lobe of the brain, and it is quite large. Here's another picture from that same scan. Here's one more. And then the last image from that scan. So this patient, due to the size and location, met with the physician, and it was determined they would use stereotactic radiosurgery. She did not want to undergo surgery, so this was the best option for her at this time. It will be planned and coordinated with the physician and the patient, and they'll kind of go from there to continue to treat her. Here's a separate patient. This is a hand where an AVM has occurred. You can see that it doesn't look like much fun. There's a lot of swelling, and if it's not treated correctly, there's a good chance they could lose that finger. Again, AVMs anywhere in the body. Here's a couple in somebody's eye. Anywhere that there's that exchange of oxygenated to deoxygenated blood, where that capillary bed is, there's always a chance that this can happen. The references that I used, and that is it for my slideshow. I hope everybody's learned something interesting. Thank you much.